and so that we get a chance for everyone to join. So just bear with us. Thank you. Gonna start now. Assalamu alaikum, everyone, and good morning, good afternoon, and good evening, depending on where you're joining from. And my name is Sarfraz Hasni. I'm the director of lupus clinical research at the National Institutes of Health in Bethesda, Maryland. And this is the last in the series for this year for the research innovation and research and innovation landscape in Pakistan webinars, which are conducted by the by APNA, the Association of Pakistani Physicians in North America Merit Subcommittee. The Merit Committee is medical education, research, international training, and transfer of technology. Today we have Professor Bilqis Shabir, who has joined us from Fatima Jinnah Medical University. She is the Director of Quality Enhancement Cell. She is going to be talking about the past, present, and future of telehealth in Pakistan. A brief introduction about Professor Bilqis Shabir is that she was the best graduate of FJMC in 1996, and she has almost 20 years of teaching experience in various medical institutions of Pakistan, including King Edward Medical College, Fatima Jinnah Medical University, where she is currently is, and multiple other medical institutes. She also has served in Bahrain in King Hamad University Hospital, affiliated with the Royal College of Surgeons, Ireland, and she has received Governor's Award for exemplary services in service delivery, research, and especially establishment of telemedicine department of excellence at King Edward Medical College. She has been serving during current floods and damage outbreaks in the country. She's also contributed in making of national guidelines and policy making in Corona Expert Advisory Group and Dengue Expert Advisory Group, and she has a special interest in endocrinology. But before I hand it over to Professor Bilqis Shabir, we have our panelists, Syed Uzair Al-Ghani and Umar Hayat, who we are very thankful and appreciative of their commitment to this series of webinar, and they will be monitoring the chat and will provide their comments at the end of the talk, and we'll take any questions in the chat. And since this will be the last in the year of the series, we have Dr. Babar Rao joining us, and he would like to say a few words, and then we will hand it over to Professor Bilqis Shabir. So Dr. Babar Rao, please take it away.
Yeah, thank you. Thank you, everybody. I'm Babar Rao. I'm a dermatologist in New York area. I'm chair for APNA Merit for this year. And I just wanted to welcome everybody and give a little quick 1 minute summary of what we have done this year. So last year, these kind of webinars, we did about 50 in 2021. This year, so far, we have done 34. And our registered participants, our total number is 2,600. And attendance average per session is around 70 to 80. So, and all these recordings for these webinars are available on our channel, APNA Merit YouTube channel, if you want to go and review that. So I just wanted to welcome everybody and welcome the moderators, and Professor Bilqis, please get us started, and then we'll see you again soon.
Thank you, Dr. Babar Rao, and Professor Bilqis Shabir, please.
Assalamu alaikum, and first of all, I must express how grateful I am to APNA Merit, Dr. Babar Rao, Dr. Umar Hayat, Dr. Uzair, Dr. Hasni, Waleed for bringing me here. And especially, it's a very significant one because it's the last in the row. So I'm very grateful for that. I'll start off with sharing my presentation. So I think you can see. Okay, basically, what I'm going to talk about is something very close to my heart, and something very new in Pakistan, and that is telemedicine. Telemedicine is reaching out to the outreached, simple. So tele means far, medicines means to treat. And as far as Pakistan is concerned, Yeah, there were some premature programs in telemedicine which were started in various sectors, but they never attained their fulfillment except for the period of COVID. COVID, where it taught us many harsh things. There were some lessons we learned out of COVID as well. And one was how to reach somebody when they cannot reach up to you. And I think telemedicine was something that was created out of the havoc of COVID, especially in Punjab, in Pakistan. And I'll tell you how it got started. My name is, I've been introduced very kindly and I'm very grateful for that. This is Fatima Jinnah Medical University, and all of you are invited to come and have a cup of tea with us and join us in any endeavors and projects you are interested in. So how it started was, it was back in the year 2020. So 26th December 2019 was when the COVID was declared as an epidemic in Wuhan. And in January 2020, they declared it as a pandemic. The first patient of COVID-19 came to Pakistan and was admitted at Mayo Hospital. And I remember very clearly, it was the 26th of February when we went to see that patient. And I think I was wearing 3 layers of PPE and mask and shields and 3 pairs of gloves. And we went to see that patient. And this is how COVID entered Pakistan. And following that, it was like sort of a volcano which erupted. Back in March, patients started pouring in, and they increased to an extent that by May, you can read this headline, it is saying that almost 90% of ICUs, I'm just talking about Mayo Hospital, they were choked. Mayo Hospital was, the capacity for COVID patients was increased to 415. And I remember in May, it crossed that number. And we at the moment had 435 patients at Mayo Hospital. So it erupted like this. And at the same time, when patients were increasing with limited resources of the country, what the government decided, as in other countries, they decided for a lockdown. And I remember that lockdown, the outdoors had to be closed. Just talking about Mayo Hospital, I won't go into the details of the other hospital. I was at Mayo, and hence I'm talking more about it. At Mayo, Delhi, it's a big tertiary care hospital. In case somebody's not fully doesn't know about King Edward or Mayo Hospital affiliated with the university. King Edward Medical University is affiliated with 7 hospitals, and Mayo is the biggest one, and it is the biggest tertiary care hospital of Punjab. And Delhi, it deals with almost 15 to 18,000 patients if we include all the outdoors. I'm just talking about the outdoors and not the ER turnover. So when the lockdown took place, the emergencies continued working, but the outdoors had also to be closed of all the tertiary care hospitals. Now, what to do with such a big load of patients? So the patients started suffering, and at that time, this is a picture showing the silver lining of the cloud. I think telemedicine was a silver lining. It struck the governor of that time, Chaudhry Mohammad Sarwar. He said that he had been at UK for, I think, about 17, 18 years. And there he had seen the growth of telemedicine. So when this lockdown occurred and the outdoors had to be closed, he came up with a view that why not start telehealth services? He basically started with tele-corona health desks. And it was on the 12th of March that he called there are 5 medical universities in Punjab, and he called the vice chancellors of all the 5 medical universities for a meeting. And he asked them to start at least 5 tele-corona health desks at their respective universities. So this is how it took place. So University of Health Sciences, King Edward Medical University, Fatima Jinnah Medical University, and other universities, they started off with a 5 to 7 desk department of tele-corona help desks at their respective institutes. And this is how it started at King Edward as well. So what I'm showing in the red in this graphical presentation is how it started. But it just, I would like to name the basic, the person who took this basic initiative. That was the Vice Chancellor of King Edward at that time, Professor Khalid Masood Gondar. It occurred to him that where the outdoors are closed, why not extend these services of tele-corona? So he called all the departments, the department you see in blue, the heads of all the departments the next day. And he requested them whether we can, sort of start it. And everybody was like, why not? And this is how we started off with telemedicine department. It was very, it was something which came out of an emergency situation, but gradually we dwell upon it. There was an e-library, which was available with almost 20 computer setups and a very good internet facility. So we involved the IT department, and he immediately converted, actually the e-library was in the process of being shifted onto a new building. So that big hall, that it was already vacated. So what we did was we made use of the already set up computers and started off with simple numbers on WhatsApp, on Skype, a simple landline, because we were expecting calls from places where there's no internet facility, talking about Pakistan. So we started off like that. And what you see in the blue, medicine, surgery, gynae, pediatrics, pulmonology, cardiology, dermatology, ENT, what you see in blue, these are the departments which started off as a next step. So there was a consultant on the counters from 8 to 2 p.m. and they would be giving free advice to whoever who called. But this was a very, premature or rather immature sort of a step. How we further dwell on it. This is how it started. You can see a portion of this hall. You can see on the left side, this guy in blue is Assistant Professor of Medicine. And together we are attending a call. I think it was a COVID call. And so this was a reception counter. So we were using mobile phones as well. We were using computers as well. We were trying to seek to maintain confidentiality of patients where required. This area, which is sort of cordoned off, is for psychiatry, because we were receiving a lot of calls from psychiatry, especially because everybody was in stress. And if you remember, there was a stress of the disease. Anybody who would catch COVID, they would get, first of all, they would go into a state of panic. The family would panic. And I remember psychiatry was the busiest counter during the initial few days. And we were also receiving calls from doctors who were exposed to COVID patients and would go home and were further exposing themselves to their elderly and the young members of the family. So they would open. So people were in a lot of stress. Doctors were in stress. So this is how it started off. This is another portion of the big hall where we started off with dermatology and ophthalmology. These are the modes of communication I'm talking. There was a lot of debate whether we are equating, our standards are equating with international standards or not. In my opinion, belonging to a country where, we used to get calls from places which I had never heard of before I had received those calls. They were so much outreached and underprivileged areas of different parts of the country. And they would be calling us on simple landlines just because they did not, landlines from a PCO or somebody, whom they would go and, request for a phone call. So that was something very, very sort of, very encouraging actually. But then as we, sort of advertised this project, more calls were received on the WhatsApp, and that was actually the busiest mode of communication. Then with time, after a few months, our IT department was very robust, and they came up with a mobile app. These are the numbers, which this is how we advertised on our website. The mobile, for example, you can see on the counter, the telesurgery counter, it has these 3 types of communications, and these are distinct for that specific counter, right? So they are different for different counters, and this is how we advertise. This is how you could connect on the internet using these login addresses. You could get an appointment, and this was the app I'm talking about. This was developed, and this app, this was absolutely free of cost app. This could be downloaded from Google Play Store, and you just a click away. You just click on medicine, and you would get in contact with the person who's on the medicine counter. You click on this pediatric call, and then there was this option of whether you would like a video call or a chat, because we did come across females talking to us over chat, preferring chat rather than exposing themselves over the video calls. So this was surprisingly a modality which was preferred and which we were not expecting would be preferred. But chatting was a modality which was preferred. This is roughly general statistics of how we went on. Till now, I think more than 20,000 patients have been encountered only at telemedicine K, and then there are different statistics for different other institutes. This is just an example. Majority of calls were from Punjab, but from other areas as well. So we would be getting calls from Gilgit-Baltistan and Khyber Pakhtunkhwa, a lot of calls from Sindh. And so this is how majority of calls were from Punjab, and obviously even more from the city of Lahore. But as I told you, more than 75 districts across the country received calls. And very interestingly, more than 45 countries across the world. So the maximum number of calls we were getting were from the Middle East. And they were our local Pakistani expats who were working there. And this facility was absolutely free of charge, where they would be talking about dinars and dirhams and euros and dollars. This was free of cost. So basically the calls were from Pakistanis who were residing there and working there. And Middle East was, you can see from UAE and Saudi Arabia, they were the maximum number of calls. But we were receiving calls from, so in total, we received from more than 45 countries. And various specialties. Medicine remained the highest, probably until now. The maximum number of calls from at all centers are of fever. Males approached us more on calls, as compared to females. And as I told you, probably because of privacy issues and the local traditions, females somehow we saw them less. And in the end, we would always ask them to fill a form and tell us whether they were satisfied with the services. So there was still about 2% which were not satisfied. And this is something we always need to work upon. So this is how it went. It's a little introduction of how it started. And at the same time, similar programs were started at Fatima Jinnah at University of Health Sciences. This is how the portal looked like for the doctor. So this data is being shared with the permission of the patient. So the name of the patient was entered with a particular, specific MRN number, and you can see the details of the history and what medication the doctor would like to give. And in the end, this is the downloadable slip of what the patient would get. And in the end, they would also always be asked to go and to the nearby health facility in case they do not feel better. So this is how, we started off with things, and with time, actually, COVID was the main issue we were dealing with. As I told you, medicine counter and pulmonology counter was running the busiest, with psychiatry in the next, and pediatrics. They were the heaviest, until now, the heaviest counters, which were receiving the maximum number of calls. So these are just examples of a few cases which are being shared with permission. So this is on the left side, we are seeing a COVID report, and this is how the patient has exchanged. These are all real cases. And this is how the patient has exchanged his chest X-ray, his CT scan. They would be sharing their videos as well. So this was the advantage of, it could be a synchronous as well as an asynchronous exchange of information. So sometimes the patient would be reaching us, and if it was beyond the 2 p.m. time, we would, get back to them. So this is how we were, sharing you can see the CT scans being shared. These are just two examples, but we were doing monitoring, and, for conditions like COVID and dengue, and many of the critical patients, where they were, there was a stage in Lahore when there was no bed in the ICU. So those who were in Lahore at that time, they would remember that people were literally begging us for beds in the ICUs, and we were not able to provide them. And that was a time when these ICU services were extended on to DHQs as well. And the DHQ personnel, they would reach us for the teams at the tertiary care hospitals, and would discuss cases. So that was a great, service, I think, that telemedicine played a role in, that we were doing sort of tele-ICUs as well. This is the patient on the right side. You can see he had an acute embolic event, and this was a case of COVID. And he was caught on telemedicine, and he was referred to a vascular surgeon. Similarly, other cases, you can see dermatological. This bruise on the right is that of a dengue patient. So when in August 2020, dengue came in, we started off with tele-dengue services as well. And till now, up to the recent crisis, this year it has been the toughest. Tele-dengue services have been established, especially for dengue patients, 24/7 at Fatima Jinnah Medical University, for patients to get access for dengue. So this is what I was talking about. This is, Government Nawaz Sharif Hospital, Yaki Gate. And you can see this monitor in the ICU, this X-ray being shared. We were reporting the ECGs and sharing ECGs. Clinical data of the patient was being shared, and we were able to discuss patients out and sort of educate each other better in management. And for the first 1 year, the management of especially COVID was very, very fluid. One day they would talk about one thing, and the next day there were contradictory views. So discussion and mutual, collaboration in treating patients was the best way we found out to deal with patients, and this is how we conducted tele-ICs as well. So this is, I remember, one of the round. This is a fast forward picture. Video of how the doctor moved around and, sort of, there were 8 patients in the ICUs, and we knew about the summaries of each and every patient. And this way we were able to see what is the FiO2, what is the oxygen saturation in response to that FiO2. And we were able to monitor the particulars of the patient every 2 to 3 hours in the ICUs. This is a very interesting patient. This is a patient who presented with fever in the surgical department with acute abdominal pain. And what you see is not carrot juice. This is a bag full of hematemesis held by the mother of the patient. And this patient was immediately, referred to the gastroenterologist, and he performed the upper GI endoscopy. And it was probably, erosive gastritis. And he was treated accordingly, and he survived actually. So, sorry, he was not a he, she. I remember she was a female patient. So this is another very interesting example. This call was from a Chinese patient, and you can see the reports which were shared to us were in Chinese language. Now, very interestingly, the girl you are seeing, she's a resident in gynecology. She received the call, and on her back, you can see in the background, there is a male doctor sitting on the pediatric counter. Now, she is a gynae resident, and he is a pediatric resident. And very interestingly, he is from China. He graduated from China. So she took help of him, and they were able, he was able to, interpret, translate the reports which were in Chinese language. So there was not only collaboration between sort of interdisciplinary approach, but very interestingly, where languages were a problem, and sometimes people would call and in Pashto and in Sindhi. So somewhere you would, because it was huge, you can see there were 18 counters, so 18 people sitting there. So you made use of that as well. Not only the clinical expertise of various departments collaborating with each other and working together as an interdisciplinary approach, but also the linguistic part of it, we took help of that as well. So that was a very interesting case, and this was an antenatal patient. And then, there are barriers to what extent we can go when we talk about telemedicine. And at one point, we do have to pull a break. But when we talk about prevention, diseases, I think telemedicine, we found telemedicine playing a very, very good role. That was a time when the vaccination started coming in. This is a picture of the EPI And we used to teach every pediatric call, every person calling on the pediatric counter, the basic, we would ask them whether the child has undergone the API or not. So we would, reiterate to them that this is something which needs to be done. So we were acting on the preventive aspect of it as well. Then when the vaccination for COVID came and people were, there were a lot of questions and people were very much confused as to whether it's safe in children and pregnant ladies. So this was something, a way where we were able to educate patients. Same is true, we established a telenutrition counter, and this was also something that I think that helped a lot. And this project was projected in Dubai Expo, and after the projection at Dubai Expo, the number of calls coming from UAE were the maximum. So people accepted at Dubai as well. And more than anything else, they were amazed at how you could do it at zero cost. So there was zero cost on the part of the patient. So that was something, and especially for the underprivileged patients. So it was recognized and in the impact rankings. And then we extended this service to KPK as well. So this was, I projected this in SNG. SNG is subnational governance, which works towards institutional and PFM reforms to improve public service delivery. So it's a collaboration between Punjab and KPK. And we participated in that as well. It was recognized at Aga Khan University as well. At the same time, I am talking more about KE, though I'm working presently at FJ, because at that time, when it was initiated, I was at KE. Now I'm at FJ. And this was how it started off in a parallel fashion at FJ. This, you can see the governor, Chaudhry Mohammad Sarwar, with the vice chancellor, Professor Ahmed Zaman Khan. He was the vice chancellor at that time. And this similar service was started at FJ, and you can see consultants sitting there and serving them. And when I joined FJ about 2.5 months back, and at that time, the floods had struck in. So what we started off in that crisis of floods was that Professor Khalid Bondal started off with telemedicine services, extending on to the flood victims. Our teams moved to the flood-afflicted areas of southern Punjab, Rajanpur. There is a village which has been established based on the donations by the faculty of Fatima Jinnah Medical University and old graduates of Fatima Jinnah Medical University. And that village, it has been named FJMU village. So we extended telemedicine services to the patients of that village when our teams were serving there. And also they served at Seven Sharif and parts of Sindh. Sindh was affected in a much worse manner, even more than Punjab. So our teams went to Sindh as well. This is a beautiful picture, and this is the expression of an affected man who is saying thanks to the university for the relief activity. So this was just in connection with how telemedicine and simple advice can help a lot, because in those areas there was definitely lack of doctors. So the doctors and the healthcare workers which were providing their voluntary services, they needed our help to make some judgments at some critical points. So that is where we were able to guide them better. This is teledengue being inaugurated, which I just mentioned. This is Dr. Umar Sardar. He was the guest of honor, and these are teledengue services. So this is a little brief of, and what we intend to do further is, this is how it is running. So I'll just play it in the background. What we plan to do is, seeing that 20,000 patients had made use of this service within a period of less than 3 years at one center. So why not create it on permanent basis at various, at least starting off with the various medical universities? So number one, our future vision carries this. Number two, very essentially, why not link them with THQs, the seal headquarter hospitals and district headquarter hospitals, and make telecenters, better equipped telecenters. Till now, we thought of starting it, but it requires funding. And that funding part of it is still lacking. So why not work on these and established one or two satellite clinics in distant areas, starting off from the province and extend on to the rest of the country. We can do that, very much doable, but we need funding for it. And we can, we need to work, private and government sector needs to work on that. Then another part of our vision is to, which is what we are working upon is, and I think inshallah we would be able to achieve it, is to establish a satellite center in the FJNU village, which we have established in the periphery of southern Punjab, in Rajapur. And that will be part of the medical facilities we are going to establish for the flood families there. That village is going to be based on 150 houses. About 50 houses have been constructed, and there are about 150 families which have been identified for that, locality. So where we plan a school and a community health center, we also plan a telehealth center, which will be communicating with the partner Jinnah Medical University, and consultant cover would be provided then. So this is our future vision as far as telemedicine at our local universities is concerned. And just to brief it up, I think that what I found, though we did not go through a very refined telehealth services, but what I felt was that we were able to reach out to the underprivileged areas. We were able to reach out to poor people for whom it is very difficult to come to tertiary care hospitals, because it costs them, money for the transportation. It costs them money because they have to, they have to take time off, and then it costs them in way of, the doctor's fee. So they could reach us, and I mean, the time is short. I could not go into the detail of very interesting other cases which we saw, but I think generally we were able to identify at least what basic treatment a patient or management, investigations and management, patients can get at home, and at what point they can be referred and should be referred to a local health service. So even telling something as basic as when to refer to a person who's, having a severe infection, or a person who's having a hypertension in the antenatal, or a person who we find is going uncontrolled in diabetes, a person who has developed an infected wound or a diabetic foot, telling them to reach a hospital as soon as possible, even that can save a life or a limb. So I felt that telemedicine has a lot of scope when we talk about our country. This is the picture. The last picture tells you it's all teamwork, and everybody plays a part in the team. The young doctors were with us, the seniors were with us, the nurses were with us, and we couldn't have done it without support of each other. So that's it from my side.
Thank you so much, Dr. Bilqis Shabir. That was excellent. And it really opens up our eyes how in a resource poor setting where we are limited resources, but still we can do so many things by being innovative and by using some out-of-box thinking. So really appreciate you taking this challenge and then developing this into this big enterprise. And like I said, then there is in every challenge there is an opportunity. So with COVID, this was the opportunity that you used, and we really appreciate you sharing your experience and some of the challenges and how you overcome that. So with that, I will hand it over to our panelists, Dr. Umar Hayat and Dr. Sayed Uzair. Please provide your comments, and also if there are any questions in the chat, if you can field those questions to Dr. Shabir also. Thank you so much.
Yes, Sumarayat, I think you can start if you have any questions first.
Okay, thank you.
Can you speak up a little?
Yeah. So amazing. I mean, as Sarfraz mentioned, in every challenge there is an opportunity, and you guys have veiled it very well. Telemedicine for sure has a room to improve. Actually, room to implement first, and then room to improve. But you guys did an amazing job. It will certainly reduce the cost. It can be cost effective. I mean, of course, somebody was asking the question, and we will go over the questions, the satisfaction the patients will get, or their the peoples who accompany them. But I think this is a with the telecommunication, how the networks are improving. Everybody has the phone, especially the touch phone with the videos. I think there is going to be enormous opportunity for the telemedicine, and especially for the country like Pakistan, where we have a huge prevalence of disease, and there is a lot of population, and there are a lot of remote areas where the access to the medicine is not easy. So I think that was a great start, and I hope you guys will continue, and funding should not be a hurdle for that. I mean, we always get a lot of donations, so I always believe donations should go to the right areas, like telemedicine would be one of them, I will say. But thank you very much. Yeah, thanks. Dr. Zar, back to you.
Thank you. Thank you very much, Professor Bilqis.
Dr. Zar, you need to speak loudly a little bit, or close to your microphone.
Am I audible now?
No, it's
Yeah.
much. Thank you.
Yeah. So, Professor Bilqis Shabir, thank you very much. What a wonderful work, and starting from King Edward Medical University to Fatima Jinnah, and I think this mission is going to move on to all the universities. So, taking this liberty and this modeling, I would like to ask, do you feel that telemedicine can be effectively used for decentralized clinical trial, which means that we can take advantage of this experience and we can apply, because this is a very fashionable word in these days, and during the COVID time, much of the clinical research is focused on decentralized trial, and we can do it. I don't know how much research is going on.
Why not? I mean, why not? Why can't we do it?
So,
Because
any
because just talking about one center, and there are others as well in the other medical universities, We have received more than 20,000 calls. So no, 20,000 is a huge number. And why can't we, so that is a basic brunt of the patient, which was actually supposed to come to the hospital initially and wasn't able to because of the lockdown. Plus those who are unable to do so because of other logistic issues. So yes, why can't we do it?
So,
And
how
actually,
many?
it's a brilliant idea.
Yeah. So, how many active clinical trials are being um, on at Fatima Jinnah Medical University? How many trials at this point in time?
You're talking about telehealth? None. Are you talking about clinical trials in general or telehealth? Because as far as I
Sorry,
know,
can you hear me?
uh, there is no trial on telehealth in any of the centers I worked based on telemedicine alone. You're asking about telemedicine, right?
Yes, my question
Yeah,
is
so
that,
there's no trial. This is what I'm saying, that we can work on this and we should actually work on this because it carries a big brunt of the patient. And as such, I don't see any clinical trial going on it. So we can do that. I mean, that can be, today can be, a day when we can plan it
good.
together.
Yeah. So
And
there
as you
was
said,
there is a comment from Fazle Vaidi. He is from KPK, and he mentioned, why can't we build the capacity? And there is going to be a free transfer of knowledge and sharing between the APNA members from North America and Pakistan. So this question is basically not addressed to you. So that is basically to the committee, research committee. Just addressing that question, lot of initiative. If you go to Apna Merit website and YouTube University, you will find there are many streams, like 6 or 7, for capacity building in family medicine, like in neurology, psychiatry, like pulmonary medicine. You will find a lot of free material, a lot of free training, one-to-one mentoring to the young medical students and to the young graduates. So you will find a lot of activity preparing the young doctors for the US exam and giving them the mock interview. So it's a full of resources. If you visit the website and if you visit the YouTube channel, so I'm going to write the link, and most of you are already familiar with that. That's regarding to this question, which is not addressed to Professor Bilkis. But my viewpoint is, again, Dr. Bilkis, I don't know that you may be knowing, you may be part of the clinical trials in Fatima Jinnah Medical University. How many active trials are being conducted at Fatima Jinnah Medical University right now? How many trials? Not on, telemedicine, but overall the number of trials. Do you have
we
any
have a
idea?
separate department of ORIC, which is basically concerned with the clinical trials. So at least I can tell about medicine because I am directly heading the department of medicine. There's a trial going on lupus erythematosus with the NIH. And I think Dr.
Yes.
Hasni is here.
Yes.
Dr. Sifraz Hasni. He is one of the stakeholders and a core person in the trial. So that is something very interesting that is going on. Then there's another trial on women health that is on the use of transamine. Then that's, I think, also with NIH. And then there's another trial which the Department of Quaiity it's not a trial. It was basically a study on COVID, the presentation of COVID in pregnant ladies, and that was with the WHO. So this is what I know of, but basically it's the department of ORIC, which deals with the, the trials which are being carried out at Fatima Jinnah Medical University. So they would be knowing better, and they would perhaps be answering this better. But these are because these are related to the medical issues, so I'm more in knowledge of these.
So, Dr. Bilkis, if I can just interject for a minute, is that I think Dr. Zair has a good point that maybe the platform that you have created, how we can leverage that platform to do the clinical trials, because I think that is the number one issue right now, is that trial enrollment and conducting the trial, and the buzzword, quote unquote, is the decentralized trials. So I think place like Fatima Jinnah, I was very impressed when I visited there 2 months ago, and to find out that the volume is so high. And then the area of my interest is lupus, and with lupus, there's so much disease there. So how we can leverage the telemedicine. So I think this is something we can brainstorm more and kind of come up with, incorporating telemedicine, and see just from the clinical, not only provide the clinical care, but we can also provide, we can also do clinical research using the same platform that you have created.
Great. Thank you, Sarfraz. So, Professor Bilkis, are you thinking, because you are a university by your own, to introduce in the curriculum about the telemedicine to your undergrad and maybe the postgrad? So, is there any opportunity or any interest, because you can do it at your own level?
Till now, because this is still new to Pakistan, it has not been included in the curriculum. But all our postgraduate residents, when this department was created, they were supposed to sit at the counters under supervision of their senior registrars and consultants and attend to calls. And very interestingly, you would, I'm talking about a country and a setup where we have more than 300 to 350, you would remember from your college years, 300 to 350 patients in the outdoor in a day, say medicine outdoor or endocrinology outdoor or surgery outdoor. So in contrast to that, when you are sitting in a tele-OPD, the number of calls will be maximum 10 to 15. They are not as yet more than that. And it's an observation which I made when I scrutinized the, slips, the prescription slips of patients which were made by the postgraduate residents. They were much better when they were sitting in the tele-OPD. And I asked them, how come you are doing terrific jobs at tele-OPD in contrast to what you do in the OPD? Because sometimes they, there's so much rush, and, the systems here are not as streamlined. The number of patients pouring in, one doctor versus 20 patients in a row. So I asked them, so they told, what general statement was that here we have time to relax and think. There we don't even get time to breathe. So this was very interesting that they were able to do, because they were sitting in a much better, environment. This is how they felt, and we did involve them. But this was not a part of the written curriculum, because telemedicine is not everywhere uniformly present in all the universities. So we cannot make it a part of a curriculum for a, generalized, till we have it in all we have this facility in all the training centers. We cannot include that. But yes, eventually, telemedicine is the way forward, and it is the need of the day. And I believe that in the coming years, as the departments become more established, why not that we carry, include it in the curriculum? And why not we carry a postgraduate, at least certificate courses on it? By the way, we ran a number of training courses for telemedicine because the residents, the consultants who were sitting at the counters, they needed to know how to address different problems. And what we did was we requested the consultants of different departments running uh, those counters to carry out workshops. And so there was a series of workshops, both online because it was initially days of COVID, and hybrid, where we conducted training session. But they were just at that specific center. They were not generalized for all because these centers are not present in all the universities.
So I think
Dr. Rosette, there is one more question from the chat box which need to be addressed, and that's from Dr. Tahra Amjad. She is Associate Professor of Community Medicine, and her question is, what was the response? I mean, ICU, tele-ICU is an excellent concept. What was the response and satisfaction level of the patients and their attendants?
Yes, this is a question very dear to my heart again. Going into the further detail of tele-ICU, there were actual doctors standing on the bedside. So it wasn't that we were just, when we are talking about an ICU involves a lot of monitoring, a moment-to-moment monitoring of the vitals, of the patient responses, the drugs being administered. So it was basically, and this concept is not new. This is, if you go abroad, you would see one critical care intensivist in a room with a row of monitors on the wall. And they would be from they may be from various centers, 2 to 3 centers. And he would be sitting there, for example, from 8 p.m. to 8 a.m. for a 12-hour shift. And he would be monitoring all those 10 to 12 monitors. And he would be advising. So monitor number 1, this is bed number 1 in center number 1. He would be advising, all right, give this drug to this patient or whatever, or monitor in this way, do this investigation. And this order would be transferred to the nurse and the doctors there. So one consultant would be, so this is basically what was in our mind. And we obviously could not establish such a, huge, again, because of the finances, but this is what we did, where we had, when all the ICUs were full of all the medical universities, we extended on to the smaller hospitals affiliated with the main teaching universities. Like I said, Yaki Gate, Kot Khaja Said Hospital, then with Fatima Jinnah Medical University, Shahdra Hospital. Then there's a small hospital in Mazang Teaching Hospital, where right now we are having 10 to 15 beds for dengue in the ICU. So the doctors there, they would reach out to us over these telemedicine services with a unit on call, and the consultants would be, giving moment to moment. It's very easy. It's very easy. You just need a WhatsApp connection. We were able, alhamdulillah, by the grace of Allah Almighty, we were able to, be helpful in when you ask me about patient satisfaction. I would never forget those patients whom we lost, but we were able to attend to them very well over these WhatsApp groups. And in some cases, in real critical patients, we used to make individualized groups as well, in order to make sure that nothing is missed for those patients. And we were, alhamdulillah, by the grace of Allah Almighty, able to save some lives as well. And I think that this is something we learned in COVID, and this is still going on. Though alhamdulillah, till now we are not struck with the new wave of COVID in Pakistan, though it has struck in China. But we are dealing with the critical patients in ICUs over the same pattern. So tele-ICU is something I think is a success story as far as telemedicine is concerned. And because the one of the reason is that patient satisfaction is there, is the doctor or nurses are present on the bedside of the patient.
Thank you. So we have one more question, Dr. Zed. That's regarding the, do we have anyone from the IT who can answer the question related to the telemedicine? So I think it's a perfect merger of IT and the medicine. So do you guys have some sort of like a strong presence of the IT in your department to support the telemedicine?
At King Edward, I think we were able to extend our services because of the IT department. Luckily, the director IT at King Edward is a PhD, and he is excellent. He was the one who created this software himself. And, if we had bought this software, it would have cost in dollars, I don't know how much. And he was the one who made this telemedicine app. And I would request all of you who are watching this, I think there are 50 people plus 5. If you could download that app on your Android, Google App Store, it's TeleMed, it's KEMU telemedicine. And if you download it, it's just a click that makes you connect with a doctor. And I think this is something, he should actually get a prize for that. So we were able, but you know what was lacking? Let's talk about things which we were lacking. We were lacking the tele equipment. What our next aim is, when I talk about tele centers, there should be devices which are specific for telemedicine, which can help us connect with the patient directly. For example, a telestethoscope. So there is a tele center in Rajanpur, and there's one, it can be a healthcare worker, it can be, anyone trained for it, it can be a nurse, a doctor, a junior doctor, anyone trained to do so. What he can do is he can put the stent in the 8 specific areas of the lungs, and through the telemedicine, this connection, I can hear it on my computer over here. So in this way, I would be able to listen to the chest. I would be able to use tele-ophthalmoscope to look into the eyes of the patient. I would be able to use the telesphygmomanometer to check the blood pressure of the patient. I would be able to, use various modalities. And then there's a tele-ultrasound probe. He just needs to put the probe on the, say, abdomen of the patient, and I would be able, the radiologist would be able to, interpret what he or she is seeing on the screen. Same is for tele-echo. So that is what we need to establish. And, but Alhamdulillah, one should aim for the stars, and you do reach the top of the trees. So we just need a little funding. And I just heard the word funds and donations by Dr. Zair, and I, sort of grasped the offer. And why not start off with that, at least in the starting off with, some areas, 2 to 3 areas you can start within a restricted,
I will add the word fund/investment. I'm the one who is against the donations and funds. I think you're absolutely right. I mean, we need those funds to do the innovative research, and I think you pinpoint the equipment, tele-equipments to facilitate the telemedicine. So that's really great. I think one point I'd like to make, Dr. Azad, you mentioned very well.
So, Dr. Umar, if I can just interrupt you 1 quick second, is that we have 5 minutes over our time. So maybe we can just finish off with your last comment and just say thank you to everyone. And yeah, please, thank you.
Thank you. So decentralized trial, I mean, I remember when COVID hit and we were already in the middle of the trial, and the patients cannot access the doctors, or doctor cannot see the patients. It was really a nightmare. And that's where we were thinking of, like, can we take the pictures, how those pictures will be valid and so forth. So I think telemedicine certainly will, how we say, the add-on to the decentralized trial, but the regulations also need to be there, because trials are such a sensitive thing, because that based on the data from those trials, they get the approval. So I think adding telemedicine certainly has the value, but it need to be regulated. So that would be my last comment. But thank you very much. Back to you, Sir.
Okay, so thank you so much, Dr. Umar and Dr. Uzair, for your comments, and thank you for all the participants for joining today. And most importantly, thank you to Dr. Bilqis Shabir for sharing her experience and the challenges. And again, I think none of this will be possible without the background technical support from Waleed Zafar and for the rest of the team, his team. So this is the last for this year, and inshallah we'll come back with more next year. So again, thank you everyone, and enjoy the holiday seasons, and happy new year. Assalamu alaikum.
Walaikum salam. Thank you.
Thank you.
Thank you, everybody.
Allah.
Thanks. Thanks. Bye-bye.